This is just a simple picture. For example, if somebody has got left hypochondriac pain, immediately you can imagine the pain is either coming from the spleen or some stomach or some area of the stomach, even tail of the pancreas as well. So if, you have to define the pain according to the anatomical position as well. These are the list, the way we divided the abdominal areas. I'll send you my lecture later on, so you will remember that. If it is epigastrium, most of the times you can find out GORD, what we call in England and American, they call GERD, gastroesophageal reflux disease, gastritis, peptic ulcer disease, then pancreatitis, and all these lists you can find out. Like right and left renal area, you can sometimes pyelonephritis, sometimes perinephric abscess, and nephrolithiasis. These are the conditions you can see, especially right iliac fossa pain. Of course, we know appendix or appendicitis is very common, but on the right side, it's common. On the left side, diverticulitis, particularly in Western countries, is very common. But you don't forget to examine testicles, or pelvic examination is very important, because ruptured ovarian cyst or ectopic pregnancy, this kind of conditions or twisted ovarian cyst can cause severe abdominal pain and shock as well. Now, if I go right hypochondriac, you have seen that in that previous picture, I intentionally left that area empty, right hypochondriac area, because there are quite a lot of things can happen in the right hypochondriac area. It can be coming from liver, biliary tract, or other areas. If you consider about liver, of course, acute viral hepatitis, patient can present with some sort of abdominal pain. And of course, we know liver abscess, which is very common. Sometimes it could be just a simple liver abscess, sometimes it could be tubercular abscess, other conditions as well. And also non-infections, being alcohol and medication, hepatic conditions, Burkitt syndrome, and also biliary part. If we look at that, acute cholecystitis is very common, acute cholangitis, and non-infectious gallstone, biliary colic, or cholelithiasis. These are very common. But don't forget that the right side of hypochondrium and also left side, something above the diaphragm, like pneumonia or subdiaphragmatic angle abscess, which is underneath the diaphragm, can cause similar kind of abdominal pain, and patient can come to surgical department as well. Another important thing we to remember is where this radiation of the pain is going. Radiation of the pain is very important to understand. If pyelonephritis, it comes from back to the front, nephrolithiasis, or we call kidney stone, or ureteric stone, not kidney stone, that goes from loin to groin area. Pancreatitis goes to the back, abdominal aortic aneurysm, severe abdominal to back pain as well. And hepatic and biliary pathology we normally get in the right hypochondriac area, going to the back as well. There are different signs we can talk about later on. Now, for example, very common thing is right iliac fossa pain, and we all know that migratory abdominal pain secondary to appendicitis. I don't have to elaborate that thing. They can start from periumbilical region and go to the right iliac fossa area, but they're definitely present. Different patient can present in different ways. So you have to remember who is actually coming and what is the real signs and symptoms. And if it is a late appendicitis, we all know that it doesn't stay in the right iliac fossa. It can cause generalized peritonitis. So you have to be aware of that as well. If we divide it into according to the foregut, midgut, and hindgut symptoms, so stomach and proximal duodenum and pancreas is from the foregut. So most of the pains you will see in the epigastric region. So midgut, if you think about, like mid-duodenum to proximal 1/3 of the colon, mostly para-umbilical region, because this is anatomically and also embryologically the way the nerve supply is actually given to those structures. And in hindgut, distal 2/3 of the colon and rectum, of course, they're normally left iliac fossa or in the left pelvic area. But please remember, it doesn't always map the similar structure, what I'm actually showing you. It can be intermingled with other structures as well and causes pain in different parts of the body. Now, I'll show you how to examine uh, the abdomen. I know each and everyone is doing differently, but there's a system, especially I'm asking the juniors to just follow. You can actually go online and check it properly. In this country particularly, we give some numbers when the students for FRCS exams coming. We normally have got some tick boxes just to check. I'm sure in FCPS exactly the same system as well. Just check whether this gentleman or this doctor is following the steps correctly or not. So that will give you a little bit of idea. Let's see this video. I'm sure you'll be able to understand. First of all, when you go and see the patient, wash your hand. This is very important, or use something and introduce yourself, confirm the patient's name and explain what you're going to do and gain some consent that you're going to examine. I'm just doing it a bit fast forward way so that you can understand. First, inspection. We always do that. Scar, jaundice, habitus, masses, or other thing as well. Then look at the hands. If somebody is asking you to examine only abdomen, you'll examine abdomen. If somebody is asking to examine the abdominal system, you have to see hands for deep return contracture, for some clubbing, and also flapping tremor for hepatic encephalopathy. So these are the things in exam, MRCS exam, or FRCS exam, or FCPS exam. They will see whether you are aware of the conditions associated with abdominal pain or not. The examination I'm showing you is not for acute abdominal pain patients only. This is for general abdominal patients as well. And now inspection of the mouth, oral candidiasis can affect abdominal pain, lymphadenopathy. If there's a gastric cancer, you know the supraclavicular nodes can be enlarged as well in malignancy. Or in Hodgkin's lymphoma, they can come with abdominal pain as well. So that's the way to examine. Next, you can use a couple of other fingers as well. And then gynecomastia, spadenivae is suggesting that whether there's an endocrine problem or if there is any sort of problem coming out from alcohol consumption or not. But when you're going to examine the tummy, just make sure patient is supine, flat, and divide into 9 quadrants, 9 segments, as I said. Examine segment-wise, so you know exactly what to think and which organ to feel. Always ask, where's the pain? Don't examine the painful area first. Examine less painful area first. And monitor patient's reactions. Look at the face and see whether the patient is getting any pain or discomfort. That will help you to understand where the pain is. All 9 regions should be palpated superficially first and then deep. And the liver palpation, we all know that. Murphy's sign, when we examine Murphy's sign, there's another way. This is a liver examination. This is the splenic examination, which we call insinuation test. That's very important, especially for somebody with a splenomegaly. Then this is development of the kidneys from right and left side. And then the groin area you have to examine as well. This is the aortic aneurysm pulsation. We don't normally examine in Bangladesh, but I think that's a good way of knowing how to do it. Then percussion. So first inspection, then palpation, then percussion, percussing the liver dullness, and also finding out the splenic enlargement by percussion method. Urinary bladder, also you can percuss to see if somebody has come up with a distended bladder. You'll find this is shifting dullness. We did so many times in the medical patients, just to show you how to do. And then auscultation. At least for 2 minutes, you have to auscultate the area to get the bowel sound. If there is no bowel sound for 2 minutes, it means there is no bowel sound. So after obviously examining, you need to summarize with the patient and thank patient, and that will complete your exam. You can get it online. Now, special examination, as I mentioned to you earlier, for any patient coming through the accident emergency, Murphy's sign, that is for the gallbladder problem. We all know how to do that. I'm not going to show you that one. Palpable aorta, I've shown you the palpable aorta, how to examine. SWAS, obtruder, and Robson signs for appendicitis. I mean, I'm sure you're all aware of this signs. So these are the things you have to remember. And then testicular and pelvic examinations. Don't forget, especially for female, pelvic examination is very important. Testicular examination is very important. But for rectal examination, we always said that that is also should be included in your normal examination, but it's becoming more or less slightly not important nowadays. You can actually explain to the examiner that, yes, after finishing the exam, I'll do some rectal examination to see whether there's any pathology going on. And extra abdominal findings, look and see whether any rashes or anything coming out anywhere in the body. Don't forget, special group of patients. Whenever you are going to see these patients, you remember there's some patients like elderly. They can't produce exactly the same signs symptoms like a young person. So you have to be careful to find out whether the patient understands everything, whether they're deaf or they don't understand the thing you are talking about, but they can completely give different history. So you might need some help from the relatives to get the proper history. Diabetic person. Please don't forget, Bangladesh has the maximum number of diabetic patients, as far as I know, after the age of 50. So diabetic person can have neuropathies. So they might not show exactly the same signs symptoms like other people. And they might have some neurological problem with diarrhea and bowel motion as well. So you have to remember that. Immunosuppressed patient. Of course, HIV and other patients all over the world now. Not only that, some sort of rheumatological problems, they are on immunosuppressive drugs, or some cancer patients can have immunosuppressive drugs as well. Just remember, they can have more problem and their sign symptoms are completely different. So you have to remember that. Etiology of acute abdominal pain and either generalized or poorly localized. Some of the conditions you have to remember, for example, inflammatory bowel disease. It's not very common in Bangladesh, but it is very common in Western countries. Infectious colitis, spontaneous bacterial peritonitis, secondary peritonitis due to bowel perforation, or diabetic ketoacidosis. Some patients with diabetic ketoacidosis can come with abdominal pain. So you have to have this in your mind. And lastly, rare but important cause of acute abdominal pain, just don't forget, adrenal insufficiency patient can have some abdominal pain. Acute intermittent porphyria. These are all medical conditions, but they can present to surgical department with abdominal pain, abdominal migraine, angioedema, that's an allergic reaction, colonic pseudo-obstruction, herpes zoster, and rectus sheath hematoma. So these are rare causes, but still, we can actually find our patients with that. Now, the next question is coming, what are the tests you need to do? If somebody in accident emergency department or come to you, please remember only a few tests you need to do first to establish the problem. First test is, of course, full blood count or CBC, urea and creatinine, and the function test that will give you some idea. HCG for pregnancy test, especially childbearing age. You have to remember, don't forget HCG. In Bangladesh, of course, some patients are coming from village as well. They don't know exactly whether they're pregnant or not. Sometimes they can get ectopic pregnancy or some sort of ruptured ectopic pregnancy. Urine dip test is very important for urine test. Just a simple dip test will tell you whether there's an UTI or anything causing this kind of pain or not. Liver and pancreas, especially lipase, not amylase. I'll tell you why. I know amylase is cheaper, lipase is slightly expensive to do, but if you want to diagnose pancreatitis, lipase, the half-life of lipase is much, much prolonged than amylase. If they present 2 to 3 days later, you might not get base amylase at all. And amylase is not always very specific. Lactate for ischemia bowel, we all know that. And then ECG, please don't forget to do an ECG, especially MI, inferior MI. Now, imaging. What are the imaging we need to do? Of course, you have to have facilities for all sorts of imaging, but in Bangladesh, I'm pretty sure it's not available everywhere. So if somebody is asking you, what is the most important imaging you need to do? You have got only one opportunity and one thing you can do. I think as acute abdominal patients, the best imaging would be just erect chest X-ray. If you have got second facilities, then you can do abdominal X-ray. But if you don't have, just erect chest X-ray will give you quite a lot of information. So chest X-ray, and then abdominal X-ray. Then you can do ultrasound if you've got that facilities to find out what's happening. And if you're in a big, good center, then CT scan is the best way of finding out what's going on if you have got any doubt. Having said that, appendicitis is a clinical examination, clinical test, but nowadays litigations problems are coming out all over the world. So you cannot just go by what you feel or what you think. You open up somebody's appendix, and especially in Western countries, and you found to be not appendicitis, then you are legally, it can sue you. So remember, if you have got your facilities to the CT scan, when you are in doubt, your other parameters are not saying that it's appendicitis, it might be something else, then please do a CT scan. Otherwise, or symptomatic. So that was my initial talk. Now I would like to go through some cases. I'll just request you guys, if anybody is happy to volunteer, please, you can actually unmute your phone and please give me some answers if possible. I can see about 40 people are here now. So is there any student here? Do you know, Nafisa? Is there any student? Can I talk?
Nafi, why don't you volunteer?
Yeah. Is there anybody? Just, it's not a difficult question, and I'll definitely come so that we can clear our mind. It has to be interactive, and I'm not going to blame anybody. So if there's a junior doctor, general surgeon who can participate.
Sir, Assalamu alaikum, sir.
Assalamu alaikum. তোমার নাম কি? আমি বাংলাতে প্রশ্ন করতে পারি। That's absolutely fine. নাম কি তোমার?
Yes, sir.
Okay, good. এই কেসটাতে তোমার সাথে আমি করি, তাই তো? ঠিক আছে? Is that okay?
Be prepared for some exciting questions, Zakir bhai.
Good. It's a very simple question. আমি just দেখবো যে তোমাদের আইডিয়াটা কি আছে and how can you actually proceed and what can you do. A 32-year-old male is a smoker, sudden onset of severe abdominal pain of 6-hour duration, unwilling to move. If you ask him to move from this area to that area, he's not moving. Cord-like rigidity on abdominal examination, very faint bowel sound. From the history, what is your diagnosis? What do you think is going on?
Generalized peritonitis.
Yep, good, absolutely.
Maybe bowel perforation of gas-containing hollow viscous.
Absolutely brilliant. That's the way. I mean, from the history, normally 90% of the cases you'll be able to understand what's going on. Okay, so I'll show you a picture of this guy's chest X-ray. What can you see here?
Free air under the right dome of diaphragm.
Good.
Free air.
Okay.
There is a semilunar crescent-shaped air under the right dome of diaphragm.
Good. What can you see on the left side? What is this?
Sir, this may be funding gas.
Good, absolutely. It could be funding gas or it can be free gas as well. So when somebody is asking you to describe this X-ray, always try to find out this is the X-ray the way we normally describe. You've done absolutely perfectly right. But I'm just saying, if they say describe this X-ray, then you can say this X-ray is a chest X-ray, erect chest X-ray of that gentleman, that date, and it's showing both expanded lung fields on both sides. And there is no bony abnormalities I can see, but below the diaphragm on the right side, I can see some free gas. Just elaborate a little bit. There's no highlight shadows or any other abnormalities I can see. If they say, talk about this, okay? Now, what is the treatment for this patient? How are we going to treat this patient? Saidul?
I will start as I will start the patient at a nothing per oral.
Okay.
And IV fluid.
Good.
IV access and
good.
Catheterization for the measurement and of the input-output chart.
Jackie sir, please unmute yourself, please. Jackie sir, please unmute yourself.
Hello.
Can you hear me?
Okay.
Can you hear me now? Okay, sorry,
Yes,
I didn't. You unmuted everything. Now, Saidul, you said,
sir.
yeah, but always remember, Saidul, I just mentioned ABC. Always, whenever you answer, I'll make sure that airway is fine, breathing is fine, circulation is fine. They just like it. I don't know why they like it, but anyway. And the nil by mouth, IVI, analgesia, NG tube plus minus. I'm not saying that you have to always put NG tube. It's a question mark. If the patient is vomiting, then it's probably helpful. Otherwise, at the time of operation, you can put that one. Antibiotic, it depends on how much peritonitis they've got. And then operation. Which operation are you going to do now? What operation? Saidul?
Sir.
Saidul, can you tell? Yeah. What are you going to do?
Sir, I will assess the patient. If not responding to conservative management, I will offer him a laparoscopic approach for diagnostic laparoscopy.
Okay, so what conservative approach you're talking about? You have seen free gas under the diaphragm. Is there any role of conservative management for this patient?
No, sir.
So why did you say that?
Okay. If the perforation was small, it can be healed. So.
Okay, no, you're right, Saidul. I mean, I said there's an option. Of course, if patient is very elderly and there's small perforation, you cannot operate. Patient has got hundreds of comorbidities. Patient will probably die if you operate. Yes, you can do conservative management by putting an NG tube, antibiotic, PPI, and see whether there's an improvement. You're absolutely right. But otherwise, the standard treatment would be repair of this perforation, correct?
Yes,
so
sir.
Do you want to do laparoscopically or open?
If the hospital and the surgeon are expert, if we have expertise, then we can go for laparoscopy.
Okay, laparoscopy key operation.
In our setting, we traditionally do conventional open laparotomy.
Fine, absolutely fine. So what do you do in open laparotomy?
Sir, I will do explorative laparotomy by midline approach, midline incision, and just after entering the abdomen, it will help me to diagnose by seeing the color of the fluid, and if it is bile stain, that it may be duodenal perforation, and if there is a fecal matter or feculent smell, there may be ileal perforation.
Good.
And
good.
The color.
So if it is D2 perforation, what are you going to do?
If it is DU perforation, I will approach the at the right hypochondrium, and I will find the omentum and the gallbladder seat the perforated site, and I will suck the fluid, and most of the time it is bile stained because the first part of the duodenum there is duodenal contents which is bile stain, and after very gently removing all the things, I will do thorough peritoneal toileting, and I will do modified Graham patch repair.
Good, absolutely fine. So omental patch and repair intraoperative, absolutely fine. Washout is very important, and NG tube and washout. Very good, Saidul. So these are the basic things. They don't want to know how expert you are, whether you can do massive gastrectomy or not, but at least a simple perforated bowel you can repair. You have treated perfectly. So anybody, any next volunteer? Anybody else apart from Saidul? Just join in. It's very easy to talk. Any surgeon, student? Nafisa, you select somebody. Then আমি অনেকগুলি question তাড়াতাড়ি বলতে পারবো। আর আমাকে বলো কখন শেষ করতে হবে।
We have time.
Can I?
We have time, Zakir.
Hello, sir. I want to perform.
Okay. Okay. What's your name?
So this is being Dr. Waliul Islam. I'm resident of General Surgeon, BCMO.
Good, Waliul. আমি তুমি করে বলছি তোমরা আমাদের অনেক ছোট, but anyway, this is the second case. 65-year-old man, sudden severe lower abdominal pain for last 12 hours, bowel not open for 3 days, no flatus for 24 hours, pain mostly at the left loin and pelvic area, rebound tenderness in the left iliac fossa. So what are the differential diagnoses you're thinking about?
Considering this scenario, my first possible diagnosis is the case of acute left colonic acute diverticulitis in the sigmoid colon.
Good, 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 absolutely. So diverticulitis, one of the differential diagnoses. What are the other things you can think about?
There may be as that the patient has not passed bowel for last 3 days.
Mm-hmm.
So there may be, sir, divertic associated pericolitis, maybe pericolic collection may be present in the left abdomen.
Good. Anything else?
Sir,
sigmoid
ডিফারেনশিয়াল বলতে হবে কতগুলি হ্যাঁ সিগময়েড ভালভুলাস হতে পারে আর কি হতে পারে যা যা মনে আছে
sigmoid valvulus.
গুড আর কি হতে পারে জাস্ট মনে যা যা আসে ওই পাশে কি কি আছে লেফট সাইডে বা রিবাউন্ড টেন্ডেন্সি আছে yeah carcinoma of the rectum yes perforated carcinoma of the rectum
perforation হতে পারে স্যার
sigmoid colon rectum and anything else
IBD হতে পারে inflammatory bowel disease
good it can be
colitis
good এই তো না অনেক কিছু বের হচ্ছে and what else just say differential diagnosis you just add as many as you can what else infarcted bowel or ischemic bowel can be there as well তাই তো অনেক কিছু হতে পারে correct everything so যতগুলি আছে even kidney related problem you can actually talk about there as well so that is called differential diagnosis now this is the CT scan finding tell me about that what can you see in CT scan there's a marking here can you see what is this part
sir
this is maybe the sir
এটা CT scan এটা কি আর এটা কি
sir this
so CT scan দেখো তো তাই না you normally see look at the CT scan don't you yeah fine you can see quite a thickened sigmoid colon can you see it's quite thick it's a thickening because you can see the wall thickness it's very common there might be some gas within the wall as well and there's a small hole here interruption that's what they're saying okay there's a small perforated large bowel and this is the endoscopy picture of the same guy about 3 months ago what are those things you can see here
diverticular sir diverticular
good typical diverticulum okay in the sigmoid colon you're absolutely right so that's the picture now I showed you another picture and these are all diverticulum and free gas surrounding these areas so it's a perforated diverticular disease okay so how can you treat them somebody presented 65 years old with perforated diverticular disease what do you do
sir my initial management plan will be resuscitate the patient
good ABC you're fine
ABC.
good
then I will keep the patient nothing per oral I will give IV fluid analgesic antibiotic and I will monitor the intake and output and then I will as there is perforation then I will go for intervention in the form
good
of
you said intake output I mean how much urine output you normally expect from an adult per minute or per hour
it should be about 0.5 to 1 ml per kg per hour
very good I'm really impressed not like 30 mL per hour that is wrong it's a 0.5 and for children how much do you want
amount should be slightly higher 1 to 2 ml per kg
good.
per hour
Absolutely brilliant. That's the right answer. Absolutely. So how do you treat surgically this patient?
I will go for, in the aspect of our country, I will go for a laparotomy by midline incision.
Good.
And go for, I will check whether there is any collection in the peritoneal cavity, it measures an amount.
Good.
I will find out the site of perforations and surrounding conditions of the bile wall.
Good. And what operation? Definitive operation can you do?
Then operations in this patients, the possible operations should be. I will go for sigmoid colectomy.
Okay.
With or without anastomosis, or go simple Hartmann procedure.
Good. Good.
Sir, this pulmonologist procedure can be option, sir. Yeah.
Okay. So mainly Hartmann's procedure. I take it that way. Now, how commonly do you see diverticulitis in Bangladesh?
Sorry, sir, please.
How commonly do you see? কত বাংলাদেশে কি অনেক বেশি diverticulitis?
Very rare, sir. It is.
আমরা দেখি না বলতে গেলে বাংলাদেশে, তাই না? আমাদের খাওয়ার অভ্যাসের জন্য হোক, ডায়েট হ্যাবিটের জন্য হোক, but it's very common in Western countries. And I did ask that question to one of the candidates from Bangladesh for an interview. I mean, he was okay, but he didn't answer the way you actually answered correctly. Absolutely. So if you plan to have some exam, just go and see whether you can answer appropriately. You are absolutely correct now, the answer question. Now, do you know any classification, Hinchi classification of diverticulitis? Have you heard about that?
No, sir. Yes, sir. I have heard. I have heard that, but by the time I cannot remember that.
Okay, that's why. Hinchi classification is there are 4 classifications. Just quickly, আমি বলছি যেন সবাই একটু বুঝতে পারে। Hinchi classification হলো stage 1 or stage 2, small confined pericolic or mesenteric abscess. That is stage 1, or Hinchi type 1. Hinchi type 2 is large abscess, but extending to the pelvis, but nowhere else. Hinchi type 3 is involving the surrounding area, and 4th one is the fecal peritonitis. So just remember, level stage 1 or 2 or Hinchi 1 or 2, in these Western countries, we are still doing laparoscopic washout and come out, not big operation. You just laparoscopy, put it in, see whether it's a Hinchi 1 or 2. For Hinchi 1 or 2, laparoscopic washout, put a drain and come out. You'll be absolutely fine. But Hinchi 3 and 4, of course, 3 is controversial, but 4 definitely, most of the times we do Hartmann's procedure because this is a contaminated area. If there's any fecal soiling, don't anastomose bowel. There's a high chance of leakage after anastomosis. So these are the questions will be asked, and I'm sure most of you will be able to answer. Now, who is the next volunteer? Quickly. I've got a few cases quickly to see, and Farid, you'll tell me when, Shakil, sorry, not Shakil, Farid and Nafisa will tell me when to stop. Okay, I'll continue otherwise. Who is volunteering now?
You carry on, Zakir bhai.
Okay, don't worry. এই ধরনের প্রশ্নগুলি আসে, এই ধরনের প্রশ্নগুলি আমরা সিস্টেম্যাটিক্যালি যদি চিন্তা করি আমরা সবাই উত্তর দিতে পারবো, কিন্তু আমাদের হয় কি, আমাদের সিস্টেমটা আমরা যেভাবে পড়ে এসেছি বাংলাদেশে, হয়তো বা বলা হতো হোয়াট আর দ্য কজ অফ ডায়রিয়া, 15টা কজ আমরা জানি ডায়রিয়ার, কিন্তু যখন প্রশ্নটা আসে এই রোগীটা কি হয়েছে, তখন আমরা আটকে যেতাম। কিন্তু এখন অনেক সিস্টেম চেঞ্জ হচ্ছে, এখন ইন্টারন্যাশনাল এবং সমস্ত ছেলেপেলেরা ইন্টারনেটের বদলে জানতে পারছে, এবং টিচাররাও কিন্তু কমপ্লিটলি ডিফারেন্ট। এখন যারা টিচ করছেন তারা অনেক নলেজেবল, আগেও নলেজেবল ছিলেন, আমি নলেজেবল বলছি না আগের গুলি, কিন্তু আমাদের সিস্টেম ছিল ওরকম, মুখস্থ করে ফেলো কয়টা ডায়রিয়ার কজ, মুখস্থ করে ফেলো এটা কি ওটা কি, রাদার দেন প্রবলেম সলভিং। এবারে চেঞ্জ হচ্ছে দেখে এটা খুব ইম্পর্টেন্ট। আচ্ছা, হু ইজ নেক্সট ভলান্টিয়ার? কে আসছে?
আমি বলতে পারবো?
হ্যাঁ, অ্যাবসলিউটলি। যে কেউ, কে আপনার নাম?
স্যার আমি প্রথমটা অ্যানসার করেছিলাম স্যার, কেস 1।
ও সাইদুল, তুমি তো বলছো আর কেউ নাই, সাইদুল তুমি ছাড়া আর অন্য একজনকে দাও, তোমাকে আমি নিব, তুমি ভেরি গুড। হু ইজ কামিং নেক্সট? আমি বললাম তুমি খুব ফ্রিলি এবং তোমাদের সবাইকে এনকারেজ করছি, আমি নট গোইং টু কাম, আমি কোনো করে বলবো না, কাউকে ক্রিটিসাইজ করবো না, যে কেউ আসতে পারে, জুনিয়ররা আরো জুনিয়ররা আসো। কে আছে নেক্সট? এনিবডি? খুব তাড়াতাড়ি, সময়টা কম, তাহলে আমাদের সবাই শিখতে পারবো একসাথে। তুমি একজন বল, কে আসছে এরপরে?
এখানে
কেউ নাই? আচ্ছা সাইদুল, তুমি আরম্ভ করো, আরেকজন তারপরে নেক্সট প্রিপেয়ার হবে। ওকে, 55 ইয়ার্স।
গ্যাস্ট্রোকলিক ফিস্টুলা।
গ্যাস্ট্রোকলিক ফিস্টুলা কোথায়?
গ্যাস্ট্রোডিউডেনোকলিক ফিস্টুলা।
Okay, to be a 55-year-old gentleman with severe abdominal pain, vomiting for last 24 hours, now fecal vomiting, no flatus for 24 hours, had laparotomy before, for twisted bowel 2 years ago. So your diagnosis is gastrocolic fistula.
Sir, can I add something, sir?
Yes, absolutely, Alian.
Sir, maybe it is a case of acute intestinal obstruction due to postoperative band adhesion.
Good. So gastrocolic fistula ke bollo?
Sir, Saidul Anwar.
Keno Saidul bolto? Keno why?
Sir, fecal vomiting.
Is it always with the gastrocolic fistula?
No, sir.
It's a very, very rare condition, isn't it? I mean, very rarely we see the acute fistula unless somebody
As there is a history of laparotomy.
Yes.
It may happen because there may be ischemic colitis and then formation of fistula.
It can be. I agree. What is the most common thing first? Somebody had laparotomy and coming with abdominal pain and vomiting for 24 hours, and now some fecal material is coming out. What is the most common thing? Aliel jeta bollo. Addition related obstruction. Yes, addition related obstruction is very common. Number one. Number two, some sort of internal herniation and causing strangulation of the bowel inside because of the adhesion. Okay, let's see. But that was the guy who had laparotomy, and now you can see a lump, just an incisional hernia. Can you see?
Yes, sir.
And that can cause some bowel loop. Let's see the next picture. What is that picture shows?
Clear-cut pictures of a small bowel obstruction.
Plain X-ray abdomen in erect posture showing multiple bowel loops of small gut origin, as the valvuli conniventes is showing here.
Good. Valvuli conniventes. Yep. Can we actually that's it? A small bowel. A large bowel.
Sir, incomplete circular fold.
Good. What is that called? Ostration.
Hostal fold.
Absolutely. Just full small bowel is descended, but there's no large bowel shadow. You see? So if it is a distal small bowel, up to distal small bowel is actually obstructed, you can see some fecal vomiting. They will start later on. This longer. And what is this one? What is this? Who can tell? What is this? দেখতে পাচ্ছ আমি যেটাকে করছি এটা কি?
একটা external appliance.
Good. ECG monitoring lead. Nothing to worry about. Okay, now ECG monitoring lead. Yes, absolutely. Yes, ECG monitoring. Now this is a CT scan. What can you see here?
So this is an axial view of abdomen in with oral contrast, showing
কি দেখাচ্ছে?
স্যার ইন্টারসেপশনের মতো মনে হচ্ছে না।
Mainly কি দেখা যাচ্ছে? Edema of the bowel. Can you see? Very edematous bowel. Very edematous bowel. And definitely, we don't see any strangulation or intersusception here, but definitely some edematous bowel and thickened bowel wall. And you can see a little bit of hernia, which is the lower part, which we have clearly seen already. Okay, that's good. Next one. That's during a laparotomy. You found that. What are you going to do? কি করতে পারো? Saidur and Olio. What can you do?
Strangulated bowel মনে হচ্ছে স্যার।
Good. Strangulated ছিল এখন তুমি কি করতে?
But it should be assessed whether it is a strangle or the circulation is reestablished or not.
Good. How can you do that? What can you do? What can you apply?
There are some maneuvers, sir, by which I can assess. I can giving them a hot mob. If,
yes.
By applying.
So you have given hot mob for 15 minutes. It's still the same condition. What are you going to do now?
I will.
সবসময় করছো সারাক্ষণ করছো জাস্ট বলো কুইকলি what can you do
স্যার হাত দিয়ে স্যার টোকা দিয়ে স্যার বোঝা যায় যদি পেরিস্টালসিস পাওয়া যায়
no peristalsis absolutely not for 15-20 minutes you have been trying no peristalsis now
sir I will see the mesenteric vessels supplying this gut whether it is
also tender or
not. Okay,
and if not possible sir I can prick with needle to see the blood.
Okay, fine. Still very minimum. Dark. Okay, so this part of the ball is dead now. What are you going to do?
Resection.
I will resect, and if the condition of the patient is approved, then I can re-anastomose, or otherwise I can exteriorize the bowel.
Okay, small bowel exteriorization. You can do that, but I think, of course. Or other thing called damage control surgery. Have you heard about that?
Yes, sir. Drop and clip.
Yep. So damage control surgery ki kora hai?
So drop and clip, clip and drop.
Absolutely. So staple, two-end staple kore, bondo kore diye, laparostomy kore rekhe dila, and the next day when they'll go to ITU,
After 48 or 72 hours,
correct.
I can re-laparotomy.
Absolutely. And then join two ends together. Very good. So is the next one. Who can come? Amra koyekta alochona korchi jonno, that will be helpful, I believe. And I've given permission for it to stop me whenever you think it's the time. Now,
Sir, please unmute yourself and again talk, please, sir. Please, sir. Jackie, sir.
can you hear me? Can you hear me now?
Now we can hear you.
Okay, right. So এটা থেকে আসবে 76 years old warfarin for AF atrial fibrillation, came to accident emergency department, severe abdominal pain, and now hypotensive and tachycardic, general tenderness all over the abdomen. কি মনে হচ্ছে রয়েছে?
Hello, sir. Can I participate?
Yes, please, Ariel. Anyone? আমি আর কাউকে পাচ্ছি না, আমি জন্য বলছি আর যে আছে।
Considering the scenario, the patient may have
Give you
acute mesenteric ischemia.
Yes, very good, very good. That is the first differential diagnosis. কেন ischemia কেন মনে করছো?
So the patient has a history of atrial fibrillation.
Good.
From there may be a source of embolization that may migrate to the mesenteric artery. And
good. Okay. Now, arekta condition bolam oke to warfarin ache. How are you going to manage this patient now? And hypertensive and tachycardic as well. What can you do?
The initial management should be, sir, ABC.
Good. Happy. Very good. Alia, carry on.
Sir, then sir, as the patient is on warfarin, sir, we need to give sir, following after resuscitation, sir, if the patient present early, then there may be a option of initial option of mesenteric artery angiography.
Okay, you can do that to find out whether there's any particular area of lack of blood supply. But the patient is very, very hypertensive and tachycardic with abdominal pain, and lactate is very high. Lactate is 10, and he's 76 on warfarin. So your ischemic bowel, infarcted bowel. That's the picture. That's the abdominal X-ray. What can you see here? Can you see anything?
Yes, sir.
Thumbnail appearance.
Good, good. Can you see that? Thumb printing appearance. Can you see? What does it mean? Thumb printing. Can you see? Like thumb. You're just putting thumbs here. So if you get this kind of pictures, what does it mean?
The mesenteric ischemia.
Yes, infarctions and ischemia. Mesenteric ischemia, you can get this kind of. Why does it happen? Do you know why? Can you tell?
So there is maybe gas shadow within the bowel wall, mesentery bowel wall.
Why?
This is a necrosis.
Nematosis
and necrosis.
Necrosis of what?
Bowel.
Yes, not bowel. Mainly what happened in ischemic condition, the first thing dies is the mucosal lining of the bowel. Okay, so there is a mucosal lining and then gas actually goes in submucosal areas and given impressions of thumb imprinting. So it's a first thing dies is the mucosal lining and then muscular layer and then peritoneal layer and then perforation. But before perforation, you can actually get this kind of thumb imprinting. That's absolutely fine. Good. I'm absolutely happy. I don't want to go any further. So operation depends on whether the patient is stable or not. If it is resectable or not, you do laparotomy and find out whether there's anything particularly you can resect out and save and salvage. bring out the loop of the bowel outside, exteriorize as a colostomy, and if patient is stable, then will probably survive. Most of the times, these elderly patients come with a complete necrosis of the bowel, so you just open and close. Right, case 5. 85-year-old man on warfarin for heart valve problems, recently developed chest infection and coughing for last 2 days. Came to surgery department with painful left-sided abdominal swelling, bowel opening normally. So what do you think is going on? He's also on warfarin. Okay, I'll show you the picture. What can you see here? This is the CT scan. Saidur or Aliur or anybody, just describe the CT scan slide.
The question will
Acha, question ta abar boli. Question ta holo 85 years old man on warfarin for heart valve problem. Recently developed chest infection and coughing for last 2 days. Came to surgery department with painful left-sided abdominal swelling. Bowel opens normally. Pehla question ta? Question hoche?
Yes, sir.
Okay, next. This is the CT scan finding. What can you see here? কি পাওয়া যাচ্ছে এখানে কি দেখা যাচ্ছে যা দেখতে পাচ্ছ what can you see?
Parietal abscess.
Parietal abscess. Okay, anything else?
Sir, a large hematoma beneath the যেহেতু পেশেন্ট স্যার অ্যান্টিকোয়াগুলেন্টে আছে এটা হেমাটোমা হওয়ার পসিবিলিটি বেশি
Good. This is rectus sheath hematoma. Very clearly rectus sheath hematoma. You can see the lining at the anterior rectus sheath, and then muscle is there, but this is the hematoma. Rectus sheath hematoma. Those who are actually on warfarin and anticoagulation, very commonly, if they have got cough or straining, they can get this kind of hematoma. Very commonly seen here. We can see at least 4 or 5 cases per year in my general practice. So it's very common, but আমাদের দেশের লোকরা অত বেশি warfarin খায় কিনা আমি জানি না, বা হয়তো বা খায়, but cardiovascular patientদেরকে দেখতে পারো এই ধরনের problem নিয়ে আসতে পারে. So that is also an acute abdominal pain problem. Okay, so case 6 is 55-year-old lady admitted with a severe abdominal pain and vomiting for 2 days. Had intermittent pain right hypochondriac area for last 2 days, 2 years. So this is the picture of this patient. Anybody can see. What can you see here? Who can explain? Plain abdominal X-ray.
It's small bowel obstruction.
Good. That's the right thing. First, anything else?
Jejunal loops are seen step ladder like pattern.
Adila Zuhair, is that right? Adila.
Adila Zuhair, yeah.
Okay, Adila, very good. So small bowel obstruction.
Jejunal loops are seen step ladder pattern.
Good.
And there are multiple loops 1, 2, 3, 4, 5, 6, 7,
good.
8,
Absolutely
9.
Fine. Okay, so it's a bit too difficult to say it's a jejunal or ileal. Sometimes it's very difficult to say. So it's a small bowel loop obstruction. That's fine. From plain X-ray is very difficult to say. So if you say small bowel obstruction, fine, I agree. And anything else? Can you say anything else?
The lungs, with the heart, one is white out on the right side.
Good. Anything else, Adila? I'm really interested about one particular thing. Particularly one.
There's a wire like going through. Is there like a, what's that black mark?
This one, yeah. Not, it's a screen problem somewhere. Okay. I think not much. What else? What is there?
Pneumobilius, yeah.
Good. Can you see pneumobilius?
Yeah.
Yes. So what does it mean? What is happening? And the history was she had pain in the right hypochondriac area for 2 years.
The patient may have gallstone ileus.
Very good. Absolutely. So that's the CT scan picture.
Okay. Wow. Very nice.
Can you see? A stone is actually stuck. What is the most common site for the stone to get impacted in gallstone ileus?
Ileocecal.
No, sir. Proximal to ileus.
Yes, it's normally ileal area, normally just before terminal ileum, just before terminal ileum. Right. What do you do? How do you normally treat them?
Surgical.
What do you
You
do?
can actually try and milk it out into the rectum, or if it's not possible and if there's necrosis or something, then you operate.
Yes.
I mean, you can
One
give a
option.
neck and take
But
it out.
most of the times, by the time they get this kind of obstruction, the bowel will be quite fragile, that particular area. So even if you try to milk it out to the rectum, yes, it's
Sometimes
possible. If you can go to the ileocecal junction, you have to pass
causes
that,
perforation,
then we'll go. Yes. So just to avoid that one, what can you do?
You just give a nick and take the stone out.
Where do you make the nick? That is my question.
I will press the and after proximal in the healthy bowel, I will do any and out
Absolutely.
the
So milk it proximally. You're absolutely right. Milk it proximally. Then what kind of incision are you going to give?
Sir, I want to give a transverse incision.
Right.
Transverse incision or longitudinal
No, sir,
incision?
I will give a longitudinal incision and transverse
close
incision.
transversely.
Correct.
Longitudinal.
Correct. Longitudinal incision, but suturing it transversely, like pyloroplasty. Correct? That's good. Very good. Very good. Now, next one. Very good that Arjun submit Pelang. Case 7. 45-year-old man with severe abdominal and epigastric pain for 48 hours and vomiting, and then binge drinking for last 6 months due to family problem. Lost about 2 kg weight during this time. Serum lipase is 450. Good. So that's the diagnosis.
Acute pancreatitis.
Now, what is the first investigation you do for acute pancreatitis? Somebody presented with pancreatitis. Yes, amylase you are saying, but I know amylase is very cheap to do, but internationally we don't do amylase anymore. Lipase. Why is that?
Because it's more sensitive.
After 48 hours,
lipase increase.
I did mention why we do lipase now rather than amylase.
Lipase is more.
After 48 hours, it increased lipase because 48 hours already passed.
Correct. Right. Absolutely.
It says exactly 48 hours.
Exactly. 48 hours for you might not get. Absolutely right. Absolutely right. So what is the first investigation you do? If lipase is done, it is pancreatitis, you know that. What imaging technique you will do first?
Contrast scan of the abdomen.
Ultrasound.
So anybody?
Ultrasound.
Ultrasound. Why ultrasound? Why not CT scan?
CT scan.
Here, I think we do ultrasound first, and then we see, and then if required, we get the CT. Otherwise, we don't.
Okay, Adila, why do you want to do ultrasound first?
Non-contrast CT scan.
Okay, and what else?
Pancreatic protocol should be done with actually contrast. It should not be non-contrast. We just want to rule out if there's a pancreatic abscess or not.
Is that the reason we do ultrasound scan?
No, we do ultrasound scans to see if there are gallstones and the cause is biliary pancreatitis.
Good, Manur. I'm really happy, Manur. Right, because
but this guy has been binge drinking into this is alcohol pancreatitis, right?
It could be, it might not be, because only last 6 months he's been doing that, but he might have a pre-existing gallstone. Sure. So don't assume. Ultrasound, according to the guideline, Association of Upper GI and Surgeons in the UK and in America as well, the first is gallstone. Gallstone problem is the most common cause for pancreatitis. Second is alcohol. In everywhere, even in Western countries as well. So ultrasound scan to rule out. Why not CT scan? Why CT scan can see the gallstone, can't it?
Can I? Gallstones is not sensitive to CT.
Okay.
Good. Do you know what percent of the patients you can see with plain X-ray or gallstone? Gallstone can be seen in right?
Can I?
10 to 15.
Can we ask Humayra to comment on that?
Yes, Humayra, please.
Humayra, please come in.
I think ultrasound should be carried out first because it's actually easily available. It's cheap. It's does not give any radiation. It can define the pancreas very well. You know, whether it's swollen, whether it's got the ductal dilatation, or is it is sewn within the duct, the fluid around it, if there is any pseudocyst, free fluid, and you can also differentiate gallstones within the gallbladder or in the bile duct, and if further needed, we can go for CT scan, but ultrasound should be the first modality used in this case.
Absolutely. So please listen to her carefully. She said exactly the same point. These are the 5-6 points you have to remember. Ultrasound is the first modalities of investigations. Don't go for CT scan because in the first or second or 2 days time, CT scan might not show any sign of pancreatitis. And the gallstone has to be ruled out. CBD dilatation has to be seen. I think Humarappa did absolutely brilliant job. So remember that. So CT scan, you can see why I'm saying day 1 CT scan looks almost normal pancreas or very tiny vein edema, not at all. But in day 3, that is a guideline. If you need to do any CT scan, it should be 3rd to 5th days, not on the first day. Okay, so this, you can see the difference, the same patient, difference in the CT scan. And also radiation, you don't want to do unnecessary radiation. So guideline is ultrasound scan, followed by, if necessary, CT scan in 3 to 5 days after the pancreatitis. Good.
Yes, Humarappa.
And lipase, Humarappa, please.
Actually, CT scan, we would recommend if the patient develops complications, because all these things are seen by ultrasound. So pancreatitis can actually be managed by ultrasound, and scan may not be required unless other complications have developed.
Absolutely right. Please listen to that. You don't need to do CT scan at all unless some complications happens. That's what I'm saying.
Because
and now
I'm doing pancreatitis patient all the time and following them up for years together.
Absolutely, absolutely. If you have got a very good ultrasonographer, she or he can do everything very precisely, much better than CT scan at times. Now, this is the answer. Why why lipase, not amylase? Just look at that. The half-life of the amylase finishes within 2 days or so, 48 hours. But the lipase goes for at least a week. And lipase is slightly expensive, but lipase is much more specific
very much
for diagnosis. In UK and America, we have started lipase now. Okay. Now, a couple of short cases, then I'll finish. Case 8 is 35-year-old gentleman with left-sided back and loin pain for last 3 days. No dysuria, no alteration of bowel habit, no loss of appetite, no weight loss, and seen some rash at the left loin today. What's the diagnosis? We think about it. Some rash, all of a sudden appeared 2 days after the abdominal frank pain.
Herpes.
A left perinephric abscess.
Good, good. Herpes. Absolutely. From the history, you can see there's a very typical of herpes zoster lesion, and sometimes you can actually very classical. They normally get pain 2 to 3 days before this rash appears. So don't always think that when every investigation is fine. Just look at the back and see whether there's a small eruption of herpes symptoms coming out or not. Very important.
Before the rashes come out, you get kind of muscle pain, for 2 to 3 days before the rash comes out.
Yeah,
and gradually a little bit of blisters, and then this kind of rashes show up.
Absolutely, absolutely.
It is actually a preherpetic neuralgia which the patient is suffering from.
Good, Manur, you're absolutely right. Absolutely. But that's what I'm saying, that don't forget about other things about abdominal pain. Case 9 is 55-year-old man, came with epigastric pain of 6 hours duration, vomited several times and sweating profusely. This guy smokes 20 cigarettes per day and overweight. What is the diagnosis you're thinking?
Myocardial infection.
Right, good. So now tell me, what can you see here? Who can read that ECG? Surgeons can read the ECG as well. So don't think that surgeons can't.
ST segment depressions. Depressions.
2, 3 and AVF. 2, 3 AVF. Inferior MI.
Inferior MI.
Okay, Obaidu. 2, 3 AVF. Good. This is the lead 2, 3 and AVF. Why? Why 2, 3 and AVF?
K1.
Inferior MI, sir.
Inferior MI, correct. Because lead 2 and lead 3 is facing from the leg towards the undersurface of the heart, correct? And AVF also on the left foot, and that's looking from below. So the inferior MI will come up with ST elevation on 2, 3, and AVF. You're absolutely right. Correct. Good. So what's the treatment for this guy?
Primary PCI. within.
Before that, you came here with abdominal pain.
Anti-ischemics, anticoagulants.
I will start aspirin, clopidogrel,
clopidogrel 4 tablets.
And step within 6 hours.
Nitramine spray.
Yes, correct. So it's morphine or pethidine to definitely anxiety relieving, and then start all anticoagulants. Very good. Very
Monotherapy.
Good.
Monotherapy.
Absolutely. So you need to read a little bit of ECG as well. So surgeons sometimes I've seen they're reluctant, but it's very easy. Few things you can easily learn. 10K, 65-year-old presented with the right hypochondriac pain for 4 days, has high temperature and coughing out green sputum. On examination, tender right hypochondrium, reduced breath sound on auscultation of the right chest. What do you think?
Acute cholecystitis.
Could be good. And
perforated.
How often? Okay, bronchiectasis. And anything else?
It could be a liver abscess. It could be a liver abscess.
Good. And what else?
Hydatid cyst. It could be
high temperature, 38.5, coughing green sputum. And auscultation, right chest sound is reduced.
Lower lobe pneumonia can also be.
Very good. So what is the X-ray shows?
Reduced breath sounds as well.
Can you see?
Pneumonia
consolidation. Absolutely. So that is why I was saying that chest X-ray is very important. You'll find out whether there's any free gas under the diaphragm or abdominal pathology, and you can find out any chest problem causing this thing. Abdominal X-ray sometimes is very difficult to interpret. It depends on quality of the abdominal X-ray. So if anybody asks you, you have got only one chance to do one investigation, you should always say chest X-ray. That's very important. So I'll send you all this. This is the area. I mean, if you go through slightly, what is the peptic ulcer disease or peptic disease? History will be epigastric pain, occasionally radiating to the back, maybe triggered by eating. I've summarized everything in this format, in this table. So risk factors, like what are the risk factors? What is the examination? What can you actually find out in examination? And what are the tests you can do? Same for gastroenteritis. They all come with abdominal pain, but these are the things normal in gastroenteritis. White cell count will be raised. This is mostly clinical diagnosis. Small bowel obstruction. What are the symptoms you'll get? And if you read that, I'm sure you'll have some summary of different types of diagnosis from abdominal pain. So I've already given in a PDF format. You'll get that hand back very soon from Nafisa. So this is different conditions like peptic ulcer disease, gastroenteritis, small bowel obstruction, appendicitis, pancreatitis, and also you can see biliary colic, acute cholecystitis, acute cholangitis, acute hepatitis. So that will give some idea or summarize the whole thing in a tabulated form. And if you go by that, you'll never miss any diagnosis. So in summary, first of all, just remember vital signs. Even if you are asked to go and see any patient, please make sure ABC is seen properly. Then focus physical examination. If you're just only examining abdomen, then abdomen examination and pelvic examination. But don't forget to see the arm, the way I showed you, the hand examinations, neck examination, cardiac and pulmonary examination should be done as well. Key laboratory tests, as I said, complete blood picture, liver function test, metabolic profile, including kidney function test and lipase. These are enough. Other frequently considered tests, if they're women, then HCG, the pregnancy test, ischemic bowel, then lactate. Patient is young, healthy, and within cardiovascular risk factor. If they're not, then you have to do ECG and troponin T, troponin. If pain is upper abdomen and other symptoms, and chest X-ray and urinary symptoms, urine culture, you always do that. But just to summarize, numerous indications of CT scan of pelvic. It depends on what do you really want to look for. So key points to take home. Acute abdominal pain is one of the most common presenting symptoms to the emergency department. There are many etiology ranging from severity of the benign or self-limiting or immediate life-threatening, as I mentioned before as well. So please always remember, etiology is associated with specific location of the pain, but they are not always precisely anatomical. So maybe somebody has a left iliac fossa pain, or maybe right iliac fossa pain. It's not appendicitis. It could be diverticular perforation or diverticulitis. Abdominal pain can be referred from intrathoracic region as well. And the presence of rigidity, usually severe tenderness to palpation, peritoneal signs, and absence of bowel sound are consistent with a surgical abdomen, which usually requires emergency surgical treatment. So I must thank Farid and Nafisa for giving me the opportunity to talk to you. I hope this was helpful, but I'll be more than happy to give your answers later on, or you can email me. And thank you very much for listening to me.
Thank you, Zakir Bhai, for the excellent talk. And we had a good audience, and you have, thank you for sticking to all the basics, because often we forget about the basics, and to get our basics right is absolutely important. And you have cited some a good number of important but common examples of the cases that comes with acute abdomen and how you manage them. So thank you for your talk. We have, luckily, some senior dignitaries, some senior professors attending us. They have all patiently listened to your talk. If you don't mind, can I ask some comments from some of the dignitaries? I can see Professor Firoz Kader is there, and Shahadot Bhai is there. So I'll be asking Anwar Bhai as well. So one by one. So at the outset, can I ask Professor Firoz Kader to say something about from your end, please? Thank you.
I'm very delighted to see so many people listening to the wonderful presentation by Zakerullal, which reminds me of my undergraduate studies back in 80s. So he has elaborately described everything about acute abdomen and the practical aspects that have been seen clinically, and also is important for the juniors who have joined here, will be appearing for different examinations. This has been made very, very useful for them. I congratulate Ali Nafiza. I thank Zakerullal and Farid in this bad time in the whole world, being able to see. Talking about Humaira, I don't know whether she remembers me or not.
I do.
You do?
Yes. Yes.
We are from the same institution, and her husband is a good friend of mine.
Yeah.
If she agrees with me. So having said, in these bad times when we are all stuck at home, mostly the senior people, trying to devote ourselves as much as possible through online service. And this is a thing which has been taken up by we people, with the older people, trying to be internet user and becoming friendly to all these, and being able to deliberate a lot of medical and educational aspects through internet and all these. So picking up this very basic topic, I again thank Ali Nafiza, being a program of Breast Disease Foundation, but bringing up acute abdomen. This is a wonderful task she has done, I must say. And Zakerullal and Farid, they are all junior to me, and they like me very much, and I like them also very much. If again I say, as Humaira, that if they agree with me, of course. So having said all this was a wonderful program. I think it should continue. And what I can find that the juniors are coming up. In our days and in the years later, the candidates or the students who were examinees, they are a little hesitant in speaking out. But what I can see here today, that they're coming forward and they're speaking out whatever they feel, and most of them are doing pretty good. So I wish everybody good success in their clinical practice in coming days, making a good career. And I hope we'll be able to get away with this COVID-19 problem as early as possible. Stay safe and stay home as far as possible. And with all respect and prayer for the departed soul who have given their life in our medical profession for care of the COVID patients. Thank you for it. Thank you, Zakerullal, and thank you all participants and Myra as well.
Thank you, Feroz Bhai. Nafisa, would you take over and ask all the other dignitaries to have few words? Maybe start with Mannan Bhai and then we Sanwar Bhai and Shahadot Bhai afterwards and follow on. Please, Nafisa, take over.
As a question, I have one question to Zakerullal sir. And actually, during COVID situation, that hello.
We can hear you.
Yeah.
Any special precaution for acute abdomen, patient management, emergency operation or admission or anesthesia for during the COVID situation? You know that it is emergency.
আমি ভালোভাবে বুঝতে পারি এখন কোভিড এর সময় এই ধরনের ট্রিটমেন্ট কি হচ্ছে সেটা তোমার প্রশ্নটা তাই তো how can you manage okay I mean in the western countries we have got covid and non-covid patients treated in the same hospital I think Bangladesh government is trying to do the same thing as well emergency is emergency because of covid emergencies hasn't stopped it's actually continued so only thing we are doing to treat this kind of patients is safety for the patient and safety for the doctors as well. So you have to carry on doing the same treatment and same surgery. However, some of the cases you can modify. For example, appendicitis, if they are not completely generalized peritonitis, just a localized peritoneal irritation, we are treating most of the patients with antibiotic for time being, because just so that the patient don't get contaminated by the COVID infections. On the other side, we are not doing any laparoscopic appendicectomies now because the laparoscopy can generate some sort of, as I said, the aerosol generated procedures can create this COVID to go to some other parts of the, some patient can be affected also, doctors can be affected as well. So we're doing open appendicectomies in the United Kingdom now. So we just modified the things, but otherwise proper PPE is a very important thing. Our problem with the PPE is that we think that just having a mask and some sort of coverall is enough. It's not. Mask has to be very, very, very specialist fitted mask because we have got well-fitted masks for each and every one. If it is not fitted, you have to change your mask and they will give you different shape and size of mask. So proper PPE is very important to save doctors. Unfortunately, almost 60 doctors died from Bangladesh. They had probably some of them PPE, but I was just questioning whether it was a real proper PPE or fully fitted PPE or not. As a doctor, everybody needs to check that this is properly fitted, then you should not get any contamination or any infections from COVID, but carry on the normal job.
Thank you.
Actually, sir, today we have 45 participants. And actually, out of which respected Firoz Kadir sir, Anwar sir, Manan sir, and Humayna madam, Sivan sir also with us. And
also Shahadot Bhai.
Who is busy for sudden Prime Minister visit in Prime Minister visit in his hospital. That's why he cannot attend this.
I'm also pleased to see Salain Bhai has just joined us as well. Assalamu alaikum, Salain Bhai. Nafisa, carry on. Nafisa, যদি শুনতে না পাও তাহলে আমি
Shibendu sir is there. Shibendu sir from Shoradi Medical College.
Yes, I am there. Yes, I am there.
Sir, please a few words for our. Actually, I have big problem about the sound at my laptop.
তুমি তোমার ইউটিউব বন্ধ করে দাও। Professor Shubhendra, would you be able to say a few words for today's talk? Would you like to contribute anything?
Hello, can Can you?
Yes, we can hear you.
Yeah. I am Professor Shivendu Majumdar, Shahid Sohrawardi Medical College, head of the Department Radiology and Imaging. It's a very nice presentation for the acute abdomen and their radiological representation, like the very nice X-rays and CT scans.